So in the post-transplant setting, the primary complication, if one can call it that we worry about is relapse of disease. And so again, optimizing the likelihood of long-term disease-free survival by rendering the patient MRD negative prior to transplant if possible, and then following MRD post-transplant and intervening on that as much as possible is an important way of optimizing outcomes. The other complications that we see after transplants, of course, boil down principally to graft-versus-host disease and infections. I think in terms of infections, we've gotten very good at prophylaxing against bacterial, fungal, and viral infections. And we have pretty well accepted standards of care for such post-transplant prophylaxis. And most centers are doing very well in terms of preventing infections. In terms of graft-versus-host disease, I think that this is still an area that requires further advancement. There are, of course, ongoing studies looking at methods for decreasing the risk of graft-versus-host disease by either using a different form of immune prophylaxis. Post-transplant cyclophosphamide is now being investigated in different settings outside the context of haploidentical transplantation where it was pioneered. And this may be one way that we can decrease the risk of graft-versus-host disease. There are also several studies that are looking at manipulating the graft in ways to immunologically tailor it to hopefully emphasize graft-versus-leukemia effect, but minimize the risk of graft-versus-host disease. Most of these studies are not specific to ALL per se, but many of them do include ALL patients as well as other acute leukemia and MDS patients in many cases. So hopefully these advancements will help us achieve better outcomes for ALL patients.